Good morning. Yeah. I'd like to thank the organizers and Mark for including me in the program this morning, and it's a pleasure to share our experiences with you. So everything, you can see the screen okay? All good? Yeah? Okay. So I'm going to talk to you about the work that we've been doing across the region with our Quality Improvement Network. These are my disclosures, and I'd like to thank the funders for the work that we do. And what I'm going to talk to you about today is what we do and why we do it, provide some examples of national and subnational implementation of the quality improvement stigma reduction work, and then move on to the facility level, and then summarize with the way forward and lessons learned to focus on sustainability. So why do we want to bring quality improvement to the world of stigma reduction? Well, first of all, stigma is a social process, and it requires systemic action. And quality improvement helps us focus on systems of care, not just individuals. We also know that the drivers of stigma are common, but their manifestations are often contextual, which means that we have to adapt our work to each different context. Scale-up and sustainability are inherently dynamic, and we need a structured way to do that so that we can learn as we go, as we do our work. And we know that HIV programs and other facilities already support quality improvement, so we need to harness that existing capacity to focus on stigma reduction. And finally, quality is co-produced, and we need to promote partnerships among communities, providers, and governments as we move forward. So if we look at this from the epidemiologic lens, we know, and we heard yesterday, that achieving our goals for the 390s or 95s is going to require that we address stigma, and we know that if we do that, we'll have better results. But we also want to think about the fourth 90, which is good quality of life. People with HIV live long, productive lives, and we want to make sure those lives are of good quality. So we want to keep our focus on experience as well. And from the quality lens, we want to focus on equity. There are 6 major domains of quality: safety, timeliness, effectiveness, efficiency, equity, and patient-centeredness. This is a long-standing domain developed by the Institute of Medicine and supported by WHO. And equity allows us to focus on providing care that does not vary in quality because of any personal characteristics such as gender, ethnicity, geography, socioeconomic status, and medical condition. And we also know from major global reports like the Lancet Commission on High Quality Systems that quality is worst for the most stigmatized groups. And so we really need to focus on quality of care. We want to also bring together the medical lens and the experiential lens. So the technical lens allows us to focus on the effectiveness and safety of care, but it's the experiential lens that allows us to focus on equity and people-centeredness. And we bring them together in our work with quality improvement. Some of you may not be familiar with quality improvement, and so just to get us on the same page, in a very thumbnail sketch, I'm going to talk briefly about the principles of QI, or quality improvement. First of all, the principle is that every system is perfectly designed to achieve exactly the results that it achieves. And so if we want to change our results, what do we have to change? Anybody? The system, right. So we have to focus on ways in which we change the system in which we work. And we do that by understanding the system in terms of its processes, which are linked to achieve results, and to control and manage variation through continuous measurement. The idea being that every person should receive the best care every time they come into the clinic without variation. And we do this by developing solutions by teams of providers and patients, with techniques of root cause analysis and process investigation. And we iteratively test the solutions that we come up with, again with continuous measurement cycles, and focus on patient needs and promote peer learning, because we also know that as everybody is working to improve their systems, when they learn from each other, it's much more effective than being told what to do by somebody from above. And in our work, we'd like to focus on the balance between that measurement and not just focus on the data all the time, but using the data for improving systems, and not just talk about changes, but measure what we do so we don't put the wrong things into practice as we go forward. And we support that with that platform on the bottom, with the structure and the organizational process that keeps those activities going. So we were initially funded to focus on ministries of health and across countries. The countries who participated initially, Thailand, Vietnam, Cambodia, Laos, were not given any funding to do the work. So they had to buy into this and implement their own quality improvement networks. And of course, then those facilities in their networks did the work. And when our PEPFAR funding ran out and we were given funding by PLWHIV and Gilead, we brought in Malaysia and Philippines to the work. And so they've continued in the network through now. So I'd like to focus on the actions related to stigma in our work. So this is from the work of Laura Nyblade, who's a global expert in the field of stigma reduction. And Laura identified 4 immediately actionable drivers: fear of transmission, awareness of stigma, attitudes, and the institutional environment. And these can lead to stigma, whether experienced, perceived, anticipated, or exacerbation of internalized or self-stigma, which then can in turn lead to harassment, avoidance of care, and unpleasant experiences. And that can affect all of our clinical outcomes as well. What we do is we take clinical data when it's available that's disaggregated by different groups, merge it with the data from Laura's healthcare worker survey, which I'll talk about in just a moment, and from data from patients directly about their experience and health literacy, which helps, when it's improved, empowers them to receive and to eliminate stigma. And that gives us a much more comprehensive picture of what's happening. And now we also have community-led monitoring data. So that gives us yet another element of a way to look at what's happening and inform areas that need to be improved. So from that survey, which had 51 items, our group selected 8 measures to focus on across the network. And you see them written here. I'm not going to read them, but they focus on observed behaviors of healthcare workers, supplies in the facility and policies, and attitudes of healthcare workers. And these are measured across the country, and some have added a few additional measures. I'm going to briefly mention examples at the national level because you're going to hear about these examples in greater detail from Dr. Anita and Dr. Tawisap. But Malaysia joined late, but I wanted to point out that at the beginning, they started by bringing together their ministry HIV program, their ministry quality program, and the Malaysia AIDS Council. So they started the right way right at the beginning, and this has enabled them to scale up, and you're going to hear about that shortly. At the subnational level, I'm giving you an example from Songkhla province in Thailand, where the provincial lead started with 2 sites in the pilot, but realized this was something he wanted to see in all the facilities. And so when the changes were adapted that showed results, he scaled them up across the region. And these include trainings for all the hospitals, canceling labeling codes in records, integrating HIV information into infection control training, and bringing the stigma reduction QI work into the facility-wide quality improvement programs. And in Vietnam, Thanh Nguyen province has adopted a stigma-free province model. And they have also expanded their intervention across their province and done a lot of trainings focusing on SOGI information and education, and scaling up consumer advisory boards, which I'm going to mention briefly at the facility level. So at the facility level, here's an example from Pompisai Hospital in Thailand. And this is showing you how the quality improvement methods get addressed. And okay, so the first arrow you can't see, or maybe you can, I can't, on the left, where they identified the priorities from the surveys. And they included hearing experiences of stigma, open discussions about patients in public spaces, separate waiting areas, and putting people with HIV at the end of the queue for procedures. And so in the table, you see the interventions that they adapted and tested out, and then the results. And I'm sorry, I can't read the interventions, but hopefully you can read them on the slide. I can't see it from here, so okay. And then we also look at patient experience. Now, we don't prescribe the measurement methodology for patient experience, and so there are many ways in which facilities can do this. They can do it from surveys, they can do it from exit interviews, patient forums, storytellings, comment boxes, and the community advisory boards. And I'm going to give you some examples of the last two. The measures that we use are adapted from global patient experience surveys. There are many countries that have standards for this, and the group picked 7 of those measures. And just to point out that there's a measure specifically about whether anybody experienced discrimination and whether you were treated with respect and privacy was observed. And this is an example from Laos. And I think in my work across the globe, I've been in many places with comment boxes, but often those comment boxes are never really looked at. But in the south of Laos, they use those comment boxes, and they open them every week, and they take the information and review them in their quality committee to identify the priorities that they want to focus on for improvement. And they actually developed a stigma committee, a formal stigma committee that helps come up with the solutions in the facility to implement. And if there were complaints about individuals, the facility leadership addressed them individually. They provided health talks in open spaces about HIV, and they shared their information with a national program. And then the interventions that they also picked involved friendly greetings. Very often the worst experiences are at reception when people come in. And so they developed a protocol for a friendly greeting and a welcome speech to orient people to the facility. They had reinforcement sessions about policies and had participatory training, which brought patients and staff together to focus on stigma. This is just a picture of the spotlight and their improvement of data. Now in Vietnam, they've adapted several strategies. They've got some very robust examples of community and patient involvement. I'm focusing here particularly on the Community Advisory Board model, which has been adapted, in which the Community Advisory Board actually participates together with staff in coming up with solutions based on the identified priorities, and then helps gather data from the community to identify those priorities as well. And so they're really partners in the process. And at this, in this particular example, they implemented a peer, a peer navigation process because of the demand from the community, created flexible hours because people couldn't come during the workday, and we're helping promote access to the insurance model. They've also applied quality improvement to health literacy in Vietnam. And here's an example of applying one of the quality improvement methods, the PDCA or PDSA cycle, where they started by putting reminders in the charts and prompts for providers, showed some initial improvement, but realized that they needed to have some intervention by calling people in between visits, and that helped them really improve their literacy rates. And we know literacy is also important for our U=U work in people understanding what it means to be undetectable, and that's also very empowering and helps avoid internalized stigma. Across the network, there have been 27 interventions. I'm not going to read them. They're on our website, and they're in the literature, and happy to share the links with you. So what have the challenges been to do this work? First of all, operationalizing how quality improvement concepts and methods can be applied to non-clinical record data has been a challenge, but people have realized that they can use other strategies like healthcare worker surveys and qualitative data. Disaggregated clinical data are still not readily available, and this is a huge challenge because that can help us pinpoint if people are having poorer clinical outcomes if they're from different groups. We also know, as I alluded to earlier, that stigma is often worst in the non-HIV areas of a clinic. And so engaging the entire facility in the process to address stigma is really critical, but that can also be a challenge to engage leadership. Breaking down the hierarchy from physicians to patients is another challenge, but learning how to engage people who use the facility and who the services are for in the processes is really important. Understanding the experience of people who don't come to clinic in the first place, since this is a facility approach, is one of the limitations. But that means that we need to combine the information we're getting from the community directly, from community-led monitoring, from the stigma index, to give us a more comprehensive picture. And we need to engage leadership, as I've mentioned, to address stigma and discrimination. So how do we make stigma a routine element of our work? And this is a shout out to Thailand, and you'll be hearing more from Dr. Tawisap very shortly. This is a gathering of policymakers, providers, and clients all together, all wearing the same shirt except for the visitors in the front. And you can see some familiar faces right up in the front as well. This is just a picture of the Thailand National Stigma Reduction Plan, and you'll be hearing more about this as well. But I wanted to point out that it includes an element for focusing at the facility level in that red box, and that includes quality improvement. And so again, a shout out to Thailand for moving this forward. So where do we go from here? If we are able to continue in our network, we know that we want to have intensified focus on key population stigma and HIV prevention, including PrEP stigma and promotion of U equals U. We want to focus more intensively on intersectional stigma and self-stigma. We want to create stronger linkages among providers, people with HIV, key populations, and have more involvement of community-led organizations. We want to intensify focus on incorporating patient experience into our efforts and include the results from community-led monitoring. We want to redouble our efforts to build capacity for quality improvement across all levels of the health system and to address stigma. And we want to expand knowledge management efforts so we can do a better job of promoting the learning from the network more broadly across not just the countries who are in the region, but elsewhere. And so in conclusion, routine application of quality improvement to reduce HIV stigma and discrimination is feasible. HIV-related stigma and discrimination in healthcare facilities is actionable through organizational and system-level changes. Integration of data from both patients and healthcare workers into routine quality improvement activities is also achievable, and community-led monitoring provides an additional important source of data to inform quality improvement. Ongoing disaggregation of clinical performance data by key populations is a big priority to address health equity, and we need to focus on that. Activities to assess patient experience and treatment literacy are an integral part of reducing stigma and discrimination. We have identified a number of evidence-informed interventions that can be scaled up, and there will be more to come. And finally, sustainability of stigma reduction activities in healthcare facilities requires integration with national policy and program activities, which you're going to hear about from the next speakers, and vigilance. Vigilance to continuously address stigma in healthcare settings. Some quick pictures of different exchange meetings, including during COVID. And also, I want to take a moment to acknowledge all the people that have worked as part of this network, because our knowledge has come from everybody who's participated in it. And here's just a few of the names from different countries that have contributed to this. So thank you for your attention. Should also note that we co-convene the meetings with UNAIDS and APN+, and again, thank our sponsors who are here from ViiV and from Gilead. Thank you for your attention.